ready to get straight into it.
Okay, thanks, Doug. So, welcome. I'm going to spend most of my time, the next 20 minutes or so, talking about this kind of stuff over here. But when you measure the circulation, you really can measure two different aspects to solve a series of two different questions. On the one hand, you can be interested in speed or velocity and how that influences things like chronic kidney disease progression or the development or worsening of cardiovascular disease. Or you can measure the nature in which the waveform actually travels and reflects in the circulation. And this is called pulse wave velocity measurements. These are called pulse wave analysis measurements. So when you see PWV or PWA, V is on the velocity side, A is on the analysis side. Both are taking advantage of the fact that you can do something over and above blood pressure to evaluate the risks for eventual or future cardiovascular, cerebrovascular, and renovascular disease in these kind of people, because these measures are able to at least putatively tell you things that a simple brachial blood pressure alone is not enough in terms of information. So velocity, I'm going to deal with this kind of quickly because most of the time will be spent on central pressure measurement. But there are a series of ways and a series of vascular beds, because a velocity is simply a distance that's traveled in a certain period of time. All you have to do a velocity is stake out a section of the circulation, whether that's the arm, the leg, or the central thoracic area, or if you're in Japan, it'd be from here down to here, so the brachial ankle, pulse wave velocity. There are multiple ways to do this, and there are multiple methodologies out there. What you see here is the Excel method here, which uses a tonometer on the neck and a cuff on the leg, and it characterizes the flow wave, the pressure wave of the aortic beat from the carotid to the femoral artery. And in that section there, interposed between the two sites, is mostly aorta. Thoracic aorta, abdominal aorta, first branch of the iliac, and just the tip of the femoral. This is the Omron machine here, which uses brachial ankle. Some people have a hybrid approach, so you have a tonometer on the neck and a flow probe here, trying to get closer to the aorta itself and not include the femoral and the iliac sections. And down here on the lower right is the workhorse, if you will, at least in Europe, of where much of the pulse wave velocity literature originated. This is the Complior system here. How you measure a pulse wave velocity, turns out, is really simple. You know, an average fifth grader can do this, and so I'm pretty sure that it's possible for all of us in this room to do it as well. What you have to do is make a measurement of distance, and the distance you want to do is from here to here, but you really can't plant probes here and here to get a waveform. So the best waveform you're going to get closest to the top of the aorta is going to be from the carotid. So you're measuring from the sternal notch here to the place you can feel the carotid pulse. And then you're measuring from the sternal notch, dog leg down here, to the femoral pulse where you can feel it. And then you put those two numbers, in this case 88 millimeters, in this case 696 millimeters, you tap them both into the way the software configures itself, so you have a proximal distance and a distal distance. You might notice these are in red, these are in blue. Why is that? Because when the pulse wave travels from the heart down the aorta with each beat, it actually is going from here up to here before you measure it. So there was a little debate about this, finally buried the hatchet, but what's typically done to determine the distance in which the wave traveled is to subtract the carotid from the sternal notch to femoral. So when you subtract the 88 from the 696, you get a value of 608 down here. That's your delta distance. Once you have your distances in, you put a couple of EKG leads on, and you capture a limb lead 2 type of QRS complex. And what the system will now do is measure the time elapsed from the tip of the QRS here with each heartbeat to the onset of the pressure wave at the two sites. Here you can see you can drive, maybe a roller skate in between here, but you can drive a semi in between here. You can really see the difference in time elapse because it takes longer for the pulse wave to travel. Once the electrical phenomenon occurs to initiate systole, it takes longer for the pulse wave to travel down to here, so that you see the foot of the wave in the femoral here, compared to how long it takes for it to get up to the carotid. So this took on average 59 milliseconds. This took on average 133. You measure it over 10 seconds of time so that you capture a breath or two in terms of respiratory cycling, because there's a little bit of change in blood pressure and pulse wave velocity with breathing. And what you really want to get is a bit of the ensemble effect. And so after 10 seconds, it'll capture that. You'll subtract your 59 from your 133. That'll give you a total of 74 milliseconds. So 608 millimeters divided by 74 milliseconds. The millis drop out. You end up with a value like this, some meters per second. Healthy people tend to be 6 or 7, maybe as much as 8, in this particular case, meters per second. People with kidney disease, on average, are 10 or 11 meters per second. And the really sick ones are up in the high teens. This is what the printout actually looks like. So here's your 10 seconds worth of data here on a 49-year-old. Here's the average value down here. And on the right of this, with the plus or minus in front of it, is the standard deviation. When you see these kind of reports, whether they're in research or someday, Lord willing, in clinical practice, that tells you the amount of variability in this particular measurement. And typically, the way to judge the quality of these things is to look at what fraction of this 7.7 that 0.8 is. When it's about 10% or less, it's a fairly good study. In the Crick study, which Doug mentioned, we use up to 15% because I'm dealing with 12 sites making these kind of measurements. So 15 is a little bit tolerant in terms of the degree of standard deviation you see with this. But rounded 7.7 up, it's 8 meters per second, 0.8, the standard deviation, so this would count as a good study. And then for extra credit, you can look here where the standard deviation of the timing is, and they're both in green. So they're very helpful. You got green and red stuff in these kind of software. And green is usually good, and red is usually bad. Now for contour, this is where we get into the pulse wave analysis thing. And there are a profusion of devices out there. The American Heart Association commissioned my group to write a summary statement on measuring arterial stiffness. And it turns out we have people from around the world contributing to this document, but the profusion of, I'm writing the section on devices used to assess vascular function. And this is just a handful of them. So they're growing in popularity, in part because they're non-invasive, they don't hurt, they yield useful information, and in part because they're starting to help us and inform us about predicting who's really at risk from vascular disease. On the upper left here is the Excel system. This is the HDI profiler. This is the Omron HEM 9000A. This is the Sphygmocor device in an older model here. And this is the Mobilograph, an ambulatory blood pressure monitor that actually takes central pressures as well as peripheral pressures over a course of 24 hours. As you can see, it gives you this kind of thing, but it also has information on what your central pressure profile looks like. In addition to standard ones produced by industry, home-built ones as well. So the literature occasionally will crop up with an article or two on some engineer that, took an old HP, monitor out of the ICU, plugged a tonometer into it, stuck it on an artery, and next thing you know, you got a waveform. And then there's software like MATLAB and other things that lets you take that waveform apart and play with it. And so there's a lot of interest. Again, after 100 years of just relying on the brachial blood pressure, suddenly the arterial waveform, the pulse, is back in center stage here, and there's a lot of interest not only in looking at it with these conventional devices, but also in the less conventional devices like the home-built ones. And it all comes down to taking this particular waveform apart and understanding the pieces that are associated with the systolic portion, the late systolic portion, the incisura, and the diastolic runoff. And there is both forward and backward traveling waves, which I'll take apart in just a second. I'm going to pause at this point and shift gears a little bit to try. So watch here, and I'll walk you through what actually occurs when one of these measurements are made. So you're looking at the computer screen. After you've turned on your computer, run the software, type in the subject's identifying characteristics, how old they are, male or female, an identifying feature. And then once you put a calibrating blood pressure in, you plant the probe on their radial artery. And once you do that and fish around a little bit, you start to see what you see on the screen here, a waveform. And notice that waveform went from kind of smallish to kind of biggish because the calibration on the side of the screen here increased. And when you see the waveform pop up to include about half the screen, you've got a good waveform. You move that probe just 1/4 of a millimeter to one side or the other of that vessel, you get this kind of noise. Moreover, as you kind of fish around for it and you get a little upset, as your tech might, and it pops off the screen because you pressed too hard, and if you leave up too much on the pressure, it goes to the bottom of the screen. The thing is incredibly pressure sensitive. There's a little bit of an art form here. It takes about a half hour to an hour to get comfortable enough with how to hold the tonometer itself. So when you plant it back on the vessel, get the waveform back, and when you see this thing occupying 2/3 to 3/4 of the screen, you've got excellent contact in a very central location of your probe, your tonometer, over top of the vessel itself. What you're looking for now is to line up the peaks. The newer version of the software actually has red and yellow lines that help you in terms of, okay, I got the red, okay, I got yellow, oh, now I got green, and you hit the space bar. Once you hit the space bar, the thing will go on to give you the actual printout. What you see here is the ensemble of that 10 seconds of radial waveform, nice, thin, peaked looking thing here. And then on the right of that was the aortic waveform, which is derived from the software itself. Great, so back to here, here, and I hope here. So here we are. What we saw just a second ago was this radial waveform. This is a little wider, notice, than the one you just saw. The software is able to take, through an internal algorithm, the characteristics of this waveform here and generate this central aortic waveform from radial to aorta. And the aortic waveform is what you would see if you had passed a catheter right up to the level of the coronary ostia in the aorta itself. Now, what you often see in terms of the useful rubric from these things is a calculation called the augmentation index. I'm going to take that apart in what I show you in the next thing here. So, the augmentation index is a function of this particular waveform that begins right here. So systole's onset is right here. If there was nothing except a straight tube forever downwind, the pressure waveform would go up like this, peak, and come right back down. So the natural pressure waveform, in the absence of any reflection and in the absence of any obstruction to flow, would simply go up, hit peak, and drop right back down. But because there is a reflection in the wave, every time the aorta changes a little in caliber, every time there's a little plaque, every time there's a branch coming off of it, every time it tapers a bit, all those set up echoes, and those echoes add up to a returning waveform called the backward or the PB type wave, and that wave comes back while the forward wave is traveling out even before systole finishes, and it generates this extra systolic load here before the left ventricle is able to close the aortic valve in systole here. So the P1 inflection point is the pressure wave for the forward traveling wave. Since the forward traveling wave looks like this and the backward traveling wave looks like that, the two algebraically combine to give you the ultimate waveform that you picked up on your radio and then transmuted to the algorithm to the central waveform. P2 is the maximum systolic pressure in the aorta itself, and the difference between P2 minus the 0 point here versus P1 minus the 0 point here, this delta P is the augmented pressure wave. If there was no reflection, this P2 value would be 0. And if there is some, then it's going to be a positive number. And one of the things we track clinically in managing people or doing research on this is to look at the amount of reflected waves effect through the augmented pressure. The delta P divided by the full pulse pressure, and the central pulse pressure is like the brachial pulse pressure. It's simply systolic minus diastolic. So if this was 110 and that was 70, this value would be 40. And if that was 110 and that's 100 and this value is 10, you'd have 10 over 40 or approximately 25%. In that situation, you would say the augmentation index, which is a ratio, is 25%. There's one or two other things on here worth pointing out before we move on. See this little TR? That's the time to reflected wave. That's when the first detectable footprint of that returning wave comes back. And notice, it's still in systole. And you have to think about this for a minute and just do a mental exercise with me. Let's say a person has a wave travel of 10 meters per second. And let's just say, for argument's sake, that their reflecting point is in the tip of their index finger. So 1 meter per second, that means 10 meters per second, a little high there, but an average kidney patient's velocity. In 1/10 of a second, a meter is traveled in terms of the distance. The typical duration of systole in humans is about 300 milliseconds, or 0.3 seconds. That means that that wave can go out, hit your fingertip, if that was the reflection point, and be on its way back and arrive at the heart before the aortic valve closes. And that's what gives you this little blip here, or in some cases a very large blip at the end of systole. Final point to make is you see this TAC, that is not tacrolimus. So TAC is total arterial compliance. Most devices on the market are interested in the systolic pressure contour. And honestly, I think that's where most of the money is going to be in the future of this field. But there is at least one device that registers the change in diastolic contour over time. And it looks at the main slope of this. That's called a C1 variable. And it also looks at what are called the harmonics buried in here, and it calls that C2. You will see some literature, and the HDI profiler is the one that does this, on total arterial compliance. But most of the time, what you see in the literature on this is oriented around the augmentation index and the central pulse pressure. Now I took, just as an example, for illustrative purposes only, we have a site in Tulane, as it turns out, not too far from here. And I took 5 patients that are in the Crick study from the Tulane study that all had brachial blood pressures of about 130 systolic, give or take a few millimeters. But I specifically checked their years by 10-year increments just for the purposes of illustration. So Crick began enrolling at the age of 18. And so here we have a 20-year-old, and you can see a nice thin waveform from the radial artery, and this little blip here, which is the tip of the detected returning wave in the radial waveform. In a 30-year-old, now at a decade of life, and you see it's a little wider here, and that little blip is gone, and it's sort of buried in this segment here. Add another 10 years, and now it's moved a little closer to the tip here, and you see this is now much wider than it was over here. Add another 10 years, and now you see the peak here with a peak and a second peak that is actually higher than the first peak, and then you get this dome-shaped effect as you add another 20 years to it. So all of these are systolics of around 130, but you can see the differences in the underlying waveform, even given the fact that the brachial blood pressure is very similar across these ages. Now, it doesn't matter. I mean, it's fun to do it, but, does it tell us anything? Well, here's one example of what it tells us. This is data from the Strong Heart Study. 4 states, American Indians, recruited because they are at high risk, as you know, for diabetes, but also for cardiovascular disease. So the Strong Heart Study specifically enrolled American Indians and looked, for example, at the development of cardiovascular disease in this group. And one of the things that Mary Roman from Cornell did was to measure not only their brachial pressures, but also their central pressures. So these are the brachial pulse pressures here in the orangish yellow bar, and the pink bar right next to it are the central pulse pressures. And as you go across the 4 quartiles of pulse pressure measurement, in the yellow are the progressively worsened degrees of brachial pulse pressure, and in the pink or salmon color are the progressive increases in central pulse pressure. And the hazard ratios for the development of a cardiovascular event in the course of several years of follow-up are what you see in these hazard ratios. And then if you just borrow your statistical eyeglasses for a second, you'll notice there ain't any asterisks here until you get to that one. And it turns out when you look at that, many of the cardiovascular events happened in this 4th quartile of the central pulse pressure, which was the only one across that trend that actually showed a significant relationship between the measurement, central pulse pressure, and the outcome cardiovascular disease. But that's in non-kidney patients. What about the people with kidney disease? So remember that number 50, because in that study here, the break point for central pulse pressure, that is in the middle, the 2 middle and the lowest quartiles, was 50 millimeters. So 50 millimeters and higher puts you in the 4th quartile of risk, at least in terms of the Strong Heart Study. We used that 50 because it was the only thing we had in the literature when we took the Crick population, about 2,560 patients apart, and we looked at the central pulse pressures measured the same way that Mary Roman did it in the Strong Heart Study. The light green bars here is the spectrum of central pulse pressures, and you have a lower limit, like any biologic variable. It isn't going to quite get to 0, but it's not too far from it. So we had central pulse pressures as low as 18, and then, like most biologic variables, there's a huge right tail on it. And when we asked ourselves the question, is there any difference? About half of Crick is diabetic, half is not. So we split the diabetics in the red here from the non-diabetics in the yellow. And although the blood pressure was a little higher in the diabetics, so that's partly driving this, nonetheless you can see the difference in the likelihood of the central tendency point being higher here in the diabetics. They're at higher risk, which is, duh, of course they are. But here's part of the issue with it is their central pulse pressures are also telling you that they have an inherently higher profile in the aorta aorta compared to the non-diabetic patients, all with CKD that we enrolled in CRIC. And using that 50 millimeters of mercury cut point for the central pulse pressures, and beginning in the lower ref and using the NKF staging system approximately, people with a GFR higher than 60, 19% of them had a central pulse pressure higher than 50. People with stage 3A, 45 to 59, a quarter had a pulse pressure higher than 50. These are central pulse pressures. Drop to 3B, now you're up to a third. Drop to stage 4, and you're at almost 50%. So as kidney function declines, and the blood pressure doesn't go up dramatically across these groups, but the likelihood of the central pulse pressure being at or above 50 millimeters does climb progressively across them. So, a couple of points to close with. The technology you use, and I showed you lots of it so far, believe it or not, kind of at Mach 2 speed. Apologize for that, but in 25 minutes you can't exactly canvas everything with, lots of time interspersed for individual characteristics of the devices. But the questions you ask determine a lot. People always say, well, which device should I use? And should I be measuring the velocity or the contour or whatever? It depends on the question you want to ask. And so we can do this a little bit of Q&A when we get to that time. You already heard about the approval of the billing code, which was an overture from the RPA to the people that do the billing, coding federally. And finally, anytime you use any device, somebody comes in with one of these things, wants to visit your practice, do a little show and tell, etc., always ask them about the validation and the source data from it. It's one of the things that's just helpful for putting that particular device in perspective. Some devices, like the SphygmoCord device, for example, have invasive characterization, so that we know that if it says the central aortic pressure is 119 systolic, it's within a millimeter of 119 systolic when you actually put a catheter up there and measure it yourself. So, final plea here, if you're interested in this kind of thing, want to join a group of largely nephrology and some cardiology that are much interested in preaching the gospel of measuring the waveform and its characteristics, naartery.org is a group that is growing, and we invite you to visit our website and to consider becoming part of our group, and thank you for your attention.